Greetings. We all have a story or an experience with death and dying. My first experience was with my maternal grandmother, Caroline Monroe, affectionately called Grammy. As a teenager, my grandmother was an important person in my life. You see, she was diagnosed with terminal colon cancer and spent much of that final year of her life enduring a major surgery and lengthy hospital stay. Now, when it was time for Grammy to die, she was transported back to hospital. In contrast, years later, my granduncle Edgar, her brother, also known as Pa, died peacefully at home in his sleep. Talk about an early introduction to the benefits of palliative care, long before I even knew it was a thing. But even then, I knew that if I could decide, I would have wanted to die just like Pa did. While death and dying are not fully in our control, there is at least one aspect of it that we can perhaps control. But in order to do this, we must be willing to first have the conversations. This is something, among others, like symptom management, that our palliative care trained specialists, especially nurses, excel at doing. We know that these conversations are hard for anyone, but they are particularly hard for those of us in the Black diaspora. Why is that? Well, there are important cultural contexts to consider. There's the history of slavery, racial discrimination, and injustice in medicine and research conducted even by the government of the United States. And yet, we know that Black Americans are 2 times as likely to have dementia, yet a still fatal disease. So these conversations are perhaps even more critical in this community if we are to ensure optimal end-of-life experiences that include culturally competent, preferent, consistent care that promotes health equity. My mission is to arm people, to help them learn how to have these conversations. Currently, we are using peer support as a vehicle to drive these conversations. This is part of the focus of my research program. So it all started with one of my previous research studies where we used a multi-partner approach to identify needs and preferences for advanced care planning or healthcare decision-making for Black Americans living with dementia and their caregivers. We included the perspectives of current and former caregivers of specifically lower socioeconomic status, along with healthcare providers and community leaders. By former caregivers, this means that their care recipient is deceased. Study results revealed the need for culturally responsive, non-judgmental, flexible caregiver support from someone with lived experience of dementia caregiving. And our former caregivers expressed that they wished to be of support to those who are currently caregiving. So based on these findings, we said lights, camera, action. And I do mean that literally. Just hang in there and you will see just what I mean. Thanks to my funding received from the Cambia Health Foundation, we were able to take peer support for Black older adults living with dementia, or peer to care, for its first test drive. And boy, what a ride it was. So by now, you must be wondering, just what is this peer to care thing? Well, wonder no more. Peer to care is a simple, cost-effective, 6-month, 100% virtual peer support program, or as we call it in the scientific world, an intervention. It is also flexible, non-judgmental, and culturally responsive by design. Our former caregivers serve as mentors to those who are currently caregiving. Importantly, it was developed with and for Black American dementia family caregivers, whereby lived experiences, including palliative and hospice care of our trained mentors, are leveraged for peer support. So to determine if folks would even be interested in signing up for and then actually completing such a program, we enrolled 26 current and former caregivers, trained our mentors, and then paired our mentors and mentees using a super fun matchmaking process. We did so in just 10 weeks. But before pairing our mentors and sending them off, we provided training, just a couple of hours over Zoom. I executively produced 4 videos, such as the one seen here, that serve as exemplars for possible mentor-mentee interactions. I hired a local Black-owned media company that secured the talent and produced the highly reviewed videos. In the end, the participants came swiftly and they stayed. No one left the study voluntarily. 90% of our former caregiver mentors and 93 of our current caregiver mentees completed the study. We had an overall program satisfaction rating of 9 on a 0 to 10 scale. These are all noteworthy achievements for any study, but especially so given the recognized challenges of recruiting and retaining Black Americans for research. And that's not all. Family caregiver mentees reported more family interaction, less perceived demands of caregiving, and less worry at 6 months as compared to baseline or in the beginning in this pilot study. So what you are seeing here is our brand asset for peer-to-care, more commonly referred to as a logo. The purple represents our current caregiver mentee who is connected to the blue circle that represents the person that they are caring for who is living with dementia. The teal represents our former caregiver mentor, and the blue connected to them signifies the person that they cared for in the past who lived with dementia. And this mentor is being of support, as you see, to their mentee who is currently caregiving. The image is not a complete infinity symbol because we know that some of the relationships may or may not continue indefinitely. But that's okay. So it is my hope that you have seen just how we asked questions of the people we intended to help, we listened, and we delivered to them the program as they requested. In the famous words of the late Lady Rosalind Carter, former First Lady of the United States, there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregiving, those who will be caregivers, and those who will need caregivers. Peer-to-care, I am thrilled to share, is taking care of the first 2 on this list. So the goal is to impact generations. I have the extreme privilege of being the inventor and founder of Peer-to-Care, a program that is showing early signs of making an impact in the lives of Black American dementia family caregivers. And for this, I am eternally grateful. This is my hard work. This is my passion. This is my calling to care.